Thanks for joining us. I'm your host, Raquel Faria. I'm an internal medicine consultant at the Centro Hospitalar Universitário de Santo António in Porto. Today, I'm joined by Professors David Isenberg and Richard Furie from the Lupus Academy Steering Committee. Between them, they will be providing expert insights from the key research and clinical data presented at the EULAR 2023 Congress, held in Milan in June 2023. David, Richard, welcome and thank you so much for joining us today.
Thank you, Raquel.
Before starting the discussion about the data presented at the Congress, I'd like to know what was your global insight of the meeting. Let's start with David.
Well, it was sort of back to the future kind of thing. I felt like I was going to the first old-fashioned EULAR/ACR meeting where one went for two reasons: one, to learn, and two, to get fit. Because I don't know about Rich, but I averaged 14,000 steps a day my 4 days there. A huge program, I believe about 14,000 people, a wide variety of topics. And for the lupus aficionados, I think very encouraging. It was nice to go to a session where most of the talks gave positive results. This is very, very rare in lupus. So I was pleasantly encouraged by that. But certainly pretty much every aspect of rheumatology was covered in great detail, and it was good to be there.
Richard.
I must say it was my first time staying in Milan, and I brought my wife, had to be honest. We had a great time. One of the highlights was not at the meeting, but we got a private tour of the Duomo using construction elevators. One of my former fellows is related to the architect who's in charge of the restoration. So that was a highlight. And the meeting was a highlight too, I must say. I'm very interested in developing new drugs for lupus, and there were some very interesting presentations, which we'll talk about.
Perfect. Actually, one of the most weighted presentation was on the last day, on Saturday. The new EULAR recommendations on the management of SLE were presented by Dimitri Bompas. There are some actual news on them, and we know that are used all over the world, not only by European lupologists. So, David, you were not on the task force for these recommendations. So, what is your outsider vision of them? Do you think they're really changing current clinical practice?
Well, I'd like to step back, if I may, because I think it's slightly odd. Dimitri Bumba is a highly experienced guy and led the group, I think, very effectively, clearly. But it's very striking to me. And the thing which really stands out is that he starts off in his presentation, and I think also in the work, by saying that lupus requires a multidisciplinary approach. That's the word, multidisciplinary. So you look at the people who make up this task force, and you find there are 35 rheumatologists. There are 5 nephrologists, dermatologists, not even the one. Pulmonologists, who are they? Neurologists, never heard of them. Obstetricians, what do they do? Hematologists, you can forget it. So it seemed strikingly odd to me that you'd go after try to updating a whole set of guidelines on a disease which you start off by saying is multidisciplinary, but then actually only really using rheumatologists to provide comments. Not to say that these people, and Richard obviously amongst them, very, very experienced people, but I found that, as they say, passing strange. I don't know, Rich, whether you want to comment on how the selection got made, because I found it very peculiar.
I was on that committee. I must say I didn't recognize that issue on the calls. What impressed me was the amount of work in looking at all these articles. And we had, I don't remember exactly how many calls, about 4 calls, perhaps each several hours long. And it was the first time I had ever done that. It was very educational for me.
So I thought that I think there were 13 statements, as they call them, and I think some of them made a lot of sense. Some of them, I think, are rather contentious. So perhaps I'll sort of quickly slip through the ones which I thought were pretty straightforward. Though Rich obviously come in at any point. So the first statement relates to hydroxychloroquine, encouraging its use as a first-line drug, maximum dose 5 mg per kg. I doubt that anybody was going to make too much of a fuss about that. Seemed quite sensible. Likewise, prednisolone reducing the standard dose for maintenance to 5 instead of 7.5. That would reflect some of the work that Michel Petrie's been talking about for years, which uses, I think, 6 mg per day as the sort of the point of liftoff in terms of side effects. So that seemed to make a lot of sense. Then we come to 3, which talks about steroid-sparing strategies, and a very odd statement which Dimitri made, that it isn't necessary to use DMARDs first if you prefer biologics. Well, you may prefer the biologics, but certainly in the UK, you can't get the biologics. We are allowed to use rituximab pretty much willy-nilly now. You can get Benlysta. It's been freed up a little bit for the first 5 years that it was after it was approved, 2016 to 2021. We could only use it for patients with skin and joint disease only. Now that's been relaxed. We can use it for renal disease, but we cannot get anifrolumab at all because AstraZeneca have decided not to go to NICE, and therefore they don't have approval, and therefore I can't use it, which is extremely frustrating. And any other biologic drugs, well, you just can't use them. And I suspect that the UK is not the only country where there are restrictions. So that was a bit odd. I mean, Rich, I'm going to take Raquel's role here, but your ability to use anifrolumab is completely unrestrained. You can use it whenever you fancy.
Essentially, yes. That was one of the big challenges in developing these guidelines, is that the resources available around the world are so different. Here in the United States, we can pretty much get any drug we want.
Yeah.
There are exceptions.
Actually, I'm just thinking about this. I remember years ago, I went to a Pan-African Congress of Rheumatology. It was around the time that the TNF alpha blocking drugs had been widely approved for the use in Europe and the States for rheumatoid and psoriatic arthritis, etc. And we're in Cape Town where the meeting was taking place. And the best talk was given by an ethicist who made fun of us all. And she said, you guys are kidding. In Africa, there are 10 major wars going on. There is no way you're going to be able to use Enbrel and infliximab and adalimumab because these countries are far too poor to be able to afford them, even if they could, even if the hospitals weren't being destroyed during these battles. So it was a slightly odd thing to have said. I mean, clearly, in a perfect world, it would be nice to use perhaps some of the biologic drugs a little earlier, and we might go on to the topic of using things like rituximab at the time of diagnosis rather than waiting till everything else has failed. But that was a slightly odd thing. There wasn't much mention of the fact that Liz Lightstone 10 years ago now showed that you could use rituximab with mycophenolate and hydroxychloroquine at the time of diagnosis in biopsy-proven lupus nephritis and not require any oral steroids in the first 2 years in I think 48 out of those 50 patients that she treated. I think that remains a pretty landmark paper, actually. It wasn't really followed up on because the clinical trial in which we tried to do in the UK fell apart when the drug company were supplying us with the rituximab decided to pull out and withdrew their funding, which was put the kibosh on it, which was a great shame. Intravenous cyclophosphamide is back. You'll be pleased to know if it ever really went away. So that can now be used. That's the full statement for organ-threatening and life-threatening disease. I suspect most people who treat patients that bad were using it anyway. Skin disease, they say that belimumab and anifrolumab can help. And I'd be very interested, Rich, what's your current view about anifrolumab? Because Ed Vitale presented at EULAR last year from the UK when we were allowed to use it. 8 terrific patients who'd failed everything else, including rituximab, including Benlysta, did marvelously with anifrolumab. Is that still true in your experience?
Yes, I mean, we recognize the value of interferon inhibition going all the way back actually to sifilumab. And we certainly saw that with anifrolumab, and in practice, that's my go-to drug for patients who are not doing well skin-wise on hydroxychloroquine. And not only have I seen resolution of the inflammation, I've actually seen in really bad discoid lupus repigmentation. Wow. I'll have to send you some of those photos.
That's amazing.
Yeah, after anifrolumab, Richard? After anifrolumab?
With anifrolumab, yeah.
Oh, perfect.
I'd love to be able to use it. I really would. Can you use it in Portugal?
Yes, we are using on an early SX program, and actually we are hoping to be available to current use on the end of the year. So we do have some patients now in our center that did.
I'm profoundly and deeply envious, I must say. I wish we had it. So the seventh statement went on to talk about hematologic disease and claim that mycophenolate was the new kid on the block, which I thought was a little funny because I don't know if Rich was involved, but there was a trial many years ago comparing mycophenolate and cyclophosphamide in patients with lupus nephritis. But because we were using the BioLeg system, we could demonstrate that actually mycophenolate was very good at a whole range of for helping a whole range of other lupus features. But maintenance was reckoned to be things like rituximab, azathioprine, mycophenolate, cyclosporin. So that was kind of okay, I guess. Lupus nephritis, emphasis again about the use of low-dose IV cyclo or mycophenolate, but also recognizing the introduction of belimumab and calcineurin inhibitors such as tacrolimus or tacrolimus, as the renal physicians like to call it, and voclosporin. Again, voclosporin, interestingly, has just been approved by NICE, which was a very considerable surprise. Mm-hmm. But I have to say, and I'm fascinated to know what Richard's experience has been, but the nephrologists in our institution at University College are a little bit skeptical about the use of Benlysta and a bit uncertain about exactly where to use voclosporin. Maybe it's just just lack of experience with it, but I'd be fascinated to know what your experience has been, Rich or Raquel.
Well, so here, the nephrologists obviously use calcineurin inhibitors, so they're more comfortable with voclosporin, whereas rheumatologists have been using belimumab now for a lot of years, 12 or 13 years, and we feel more comfortable with belimumab. And belimumab clearly has a nice safety record, and there's still that uncertainty about long-term kidney damage from calcineurin inhibitors, so that will be sorted out hopefully soon. So is there a lot of use of voclosporin? I get the impression, I mean, I don't have numbers, but I get the impression there's not a lot of use of voclosporin. I don't know how much use of belimumab there is in lupus nephritis either. But my feeling is 2 drugs are better than 1 drug. So all my patients with proliferative disease, and for that matter, membranous, even though membranous didn't seem to do so well in those studies, I will give mycophenolate as background, and then add on either voclosporin or belimumab.
As we went there, can I ask you, Richard, in which patients would you use belimumab or voclosporin from the beginning of the lupus nephritis? Do you have an idea local protocol for that?
We do not have anything written as far as a protocol goes. But you can't tell who's going to do well or not. And therefore, I would advocate for 2 drugs over 1 drug.
Okay.
So the 9th statement related to what to do after initial therapy where you get a renal response in patients and how long you should maintain the treatment, be it mycophenolate or belimumab. And 3 years seems to be the sort of the current number. Yeah. And I must say, I feel fine with it. I don't have a problem with that. I think that's pretty much my practice anyway. And the EULAR targets are reducing the protein creatinine ratio by 25% by 3 months and 50% by 6 months. I had no problem with that either. The 10th statement related to the use of very high doses of IV cyclo in combination with pulse methylprednisolone for patients at high risk of renal failure. Again, I didn't have a particular problem with that. Then there were some issues around tapering, and if you've got patients on an immunosuppressive and steroids, which would you reduce first? And the EULAR view is that you should try to get the steroids down first. Again, I could certainly live with that very happily. The 12th statement was, to me, more contentious. And I suspect you will both know where I'm coming from on this. So this is the question of thrombotic APS in the context of either presumably primary or secondary disease, but particularly associated with lupus. And the statement is that thrombotic APS should be treated with long-term vitamin K antagonists. Now, that to me lacks any kind of nuance. And there's just been a beautiful review just appeared in the Journal of the American College of Cardiologists by somebody called Kandika Karani, which says very clearly, and I would utterly endorse this, that they did a very detailed systemic review and meta-analysis before the clinical trials that have been done, comparing the safety and efficacy of DOACs versus VKAs in patients with thrombotic APS. And they conclude that there is indeed, as I think everybody would accept, increased odds of arterial thrombotic events, but, and this is the important thing, no significant change in the odds of venous thromboembolic events. And that's exactly what we found in the RAP study, that especially if you've just got 1 or 2 antiphospholipid antibodies, but not 3, and you've just got a venous event like a deep venous thrombosis, it's frankly much kinder, I think, to the patients to put them onto a DOAC because they don't have to have a blood test every week. They're not restricted in terms of a large number of other drugs, and a large number of foods. And there is no data to suggest that you couldn't use a DOAC perfectly adequately in that situation. That's certainly our practice. I don't know what you've been doing, Rich and Raquel. What's your view?
Richard?
Well, I am a believer in warfarin and a vitamin K antagonist, and certainly for arterial events, aggressive anticoagulation. For venous events, I still do the same. I go with warfarin, though the problem is, in reality, are you better off with a DOAC in a non-compliant patient or warfarin where they don't go for blood testing? And I haven't figured that one out yet.
For us in Europe, it's a little bit strange because EMA just found that DOACs would be contraindicated in antiphospholipid syndrome. So it's not a good thing, except if there is really a good justification for that. We're not allowed to use DOACs for antiphospholipid syndrome patients. So it's a little bit sneaky for Europe.
Because I think I'm right in saying that the European recommendations with regard to APS actually do allow DOACs in the situation of not triple pos and venous, not arterial. And as I say, from my perspective, from the patient's point of view, it's just a much kinder drug to be on. And the evidence, I think, is that it's very reassuring. Anyway,
wait, I have a question for both of you.
Yep.
And I don't know the data. As far as crossover from people who've had venous events to then having an arterial event. I assume it's a low number, but I don't know what that number is.
Yeah, it is a relatively low number, and it's probably in the region of 10 to 15%, maybe, I'd guess. I'd have to go and look that up to be sure, though. And in that situation, definitely you'd switch to VKs at that point, definitely. Well, I would anyway. And then the 13th statement, just to finish it off, relates to immunization and adjunctive therapies, emphasizing the need for conventional immunization. In fact, it's an interesting question, which I've been looking at quite recently, about what immunizations you should use and when and how to use them in relation to biologic therapies in lupus. But that's a whole other story, which we probably don't have time for today.
So, Richard.
Just a comment. So I must say those statements are obviously very condensed and don't tell the whole story. So you have to read the text that will come out, I guess, fairly soon. Issues that were controversial related to lupus nephritis, and then something as simple as hydroxychloroquine. I order blood levels, but obviously, again, we talk about resources around the world. Not everybody has access to whole blood hydroxychloroquine levels, but I ignore the 5 milligrams per kilogram. I just get a blood level every time I see the patient.
And actually, you're because you're absolutely right. One of the greatest shocks I had in my career was when I got asked by colleagues from Paris, Nathalie Chelnaud-Costa-Doa asked me to take part in a study in which, I think I got her surname split rather away, so apologies, Nathalie, if you're listening. But I was asked to take part in a study which I would send her 50 odd blood samples from patients who I thought were taking hydroxychloroquine, and I tried to choose the patients who I was pretty confident they'd be taking them. It was horrifying actually when I discovered that 30% of these 50 patients had levels which were either 0 or close to 0. It was quite shocking.
So
it's very upsetting because you extend that to the other drugs.
Absolutely.
And, we'll kill in a clinical trial to see an effect size of 15 percentage points. We may be able to achieve that by having patients come for appointments and taking their medicines.
Yes. Just to try to wrap up the EULAR guidelines theme, Richard, in regard of the countries that do not have access or rapid access to biologics, how do you think these new recommendations help the clinical practice? Do they add anything else to the latest one?
Well, we discussed that too. So these statements, these guidelines were supposed to just add on to what was previously published. But you're asking the wrong person. I'm not a big fan of guidelines. I went into rheumatology so I could develop my own guidance. I would have gone into oncology if I liked guidelines and algorithms. So I hope we can maintain some independence.
Okay, David, do you have anything heading this particular aspect of the recommendations?
No, only a general point that I think it's an important question to ask. How often do these guidelines really need to be revised? I kind of feel 5 years should be a minimum. And the last set of EULAR guidelines were out 4 years ago. And of course, we've had this little pandemic thing in the last 4 years. So not that much, I suspect, has changed. And in a way, of course, it hasn't allowed for further discussions about some of the newer kids on the block, and some quite exciting things, though I suppose unproven in the sense that CAR T-cell therapy, which we might come to, clearly does offer some very interesting potential for change and improvement. So personally, I think a guideline shouldn't be revisited for a minimum of 5 years. That would be my gut feeling.
Okay, let's move on. Richard, in all the EULAR meetings that where clinical management research were presented, what stood out the most for you and why, from the clinical management point of view?
Well, I'm interested in new therapies. And it's been, as you well know, very challenging. So what attracted me, well, there are several. So I was interested in the telitacicept data, the upadacitinib data, the ianalumab data. And it may be worth discussing interleukin-2. I'd be curious about your views. We've had 3 negative trials so far. So I don't know where you want to start.
Can you please start on the telitacicept data and comment on that?
Yeah, so the telitacicept data were presented by Ronald van Vollenhoven. But we've seen those data before, at least in press releases. And the phase 2 data led to the approval of telitacicept in China about 2.5 years ago. I have no idea how it's doing in China. But the effect sizes, and it really didn't matter which dose, they tested 3 different doses, were very robust. And they were about the same, I think around 35 percentage points at least. And that seemed to be the case with the phase 3 data that were recently presented, but again, done in China. So the big question is, how will this perform outside of China? So there is a global study being done now, so time will tell. But David certainly has a lot of experience with a very similar drug, atacicept, and he may want to make a comment.
So my understanding is that the structure of atacicept and telitacicept is remarkably similar, is the phrase that was quoted to me, as in very, very similar. And atacicept, I think, must be the world's unluckiest drug. It was started out back in about 2000, somewhere between 2005, 2007. Certainly David Wofsy and I were invited to Merck Serono in about 2007 to help design what was a flare prevention trial, the first trial really of atacicept. And that trial was stopped by a safety committee because they were concerned that there had been 2 deaths in the high-dose arm. The structure of the trial was interesting, I thought. They took patients who were active, as defined by BILAG A or 2Bs. They treated them with a short, sharp dose of steroids to get them into remission. So no BILAG As or Bs were allowed. Then they got the high dose of atacicept, the low dose of atacicept or placebo to see how many flares there would be and the time to first flare. And with the low dose, they got all the way through. That was fine. There were 150 patients in each arm. In the first trial of atacicept, in the high dose arm, the trial of the arm with the high dose component was stopped about 60 patients in because 2 patients had died. 1 patient died of leptospirosis in Manila, which I would suggest is not a common cause of death in lupus, and 1 died of bronchopneumonia in Argentina. And the safety committee ignored the fact that, unfortunately, the truth is, if you look at virtually every single lupus clinical trial, there is a death or 2. In fact, in the comparison of mycophenolate and cyclophosphamide, there were 14 deaths in a phase 3 trial. In the phase 2 trial of voclosporin, there were 11 deaths. So their safety committee said, no, carry on, no problem at all, 11 deaths, nothing, just carry on. So it was very surprising to me that trial was stopped. And then there was the very curious incident, I'm going to say in the night, but the curious incident of the renal trial using atacicept, in which 6 patients were entered, 2 got placebo, they were fine. Of the 4 who got the atacicept, 3 developed very serious chest infections and nearly died. And the company's trial coordinator at the time noted that the IgG levels of the patients who got very sick had fallen. What she had failed to observe was that they'd fallen when they were given mycophenolate before they were given any atacicept whatsoever. So that was pretty weird. And unfortunately, the company did one more trial in which there were no deaths, I think I'm right in saying, but then Merck's kind of lost interest and basically they've sold it on. And there's a smaller company in the States called Vera Therapeutics who have now acquired it. And I know they're trying to find some money to go back to looking at lupus nephritis. So that's the atacicept story. The teletacicept seems to be much more fortunate, although my memory is, I don't know if you remember this, Rich, was just before the pandemic. The data was first presented at an ACR. I think it might have been a late breaker, actually.
Yeah, that's right.
It looked great. It looked fantastic. In fact, several people said to me, it's too good to be true. But the data which was presented at this meeting looked pretty good to me. And as you say, it'd be interesting to see when it finally gets out of China to other populations to see if it's just as good. But anything which blocks 2B cell activating factors needs to be taken seriously. So I'm watching this space very, very closely, and I'm hoping it'll work.
Yeah, too good to be true is also what I said when I heard the interleukin-2 restoration data about 8 years ago at the ACR meeting. The person presenting it from China, I think, was about 2 after my presentation of anifrolumab phase 2 data.
I was there. I heard it.
The IL-2 response, it was about 90% had an SRI response within 12 weeks. Too good to be true. But as people know, they went on and did a traditional randomized controlled trial, still with very robust effect size. So a bunch of companies have presented data. I guess the first set we heard was IL-2, ILTOO, mm-hmm. And they had a little issue with a very high placebo response rate in a particular country in Europe. So I don't know where they're going with their program. And then Eli Lilly Nectar, in a press release, demonstrated a very modest effect with 1 out of 3 doses. And then Amgen, and I actually presented at EULAR some mechanistic studies for the Amgen IL-2 study, and they discontinued their program. But there's still other IL-2 programs going on. So I don't know what to say about that. It seemed very magical that you could give or replace IL-2 and lupus would get better. It may be better as a maintenance therapy, perhaps, as opposed to I hate to use the word induction therapy, but maybe as a maintenance therapy, it will hold some promise.
And do you want to comment on the ipavasitinib? You mentioned it. And please comment also on why do you think it's a promising drug compared to baricitinib, and what the company decided to stop the development in lupus?
I mean, stop the development of baricitinib?
Yes. Comparing upadacitinib to what happened with baricitinib.
Yeah, so the phase 2 study with baricitinib kind of just squeaked by. But enough so that it supported a phase 3 program. And I'm just wondering perhaps if the dose of baricitinib, the 4 milligrams, so 2 doses, 2 milligrams and 4 milligrams were tested. I'm just wondering if the 4 milligram dose perhaps was not high enough to use. As far as upadacitinib, nice data, but phase 2 to phase 3 could be very telling, so we'll see. Mm. And that program, that upadacitinib program, also included a BTK inhibitor, though it didn't seem like the BTK inhibitor really added very much, which I think is what was seen in rheumatoid arthritis. It didn't add a whole lot. So our experience with BTK inhibitors has not gone so well. At least 2 failed trials. David knows about 1 at least. So I don't know, time will tell. It's just making that transition from phase 2 to phase 3 can be very challenging.
Yeah, I agree. There are at least 4 drugs where phase 2 looked pretty good, including eprotuzumab, for example, but unfortunately phase 3, it's a problem. One thing that you have to look at in particular, and Rich has highlighted this, is you've got to look very closely at the placebo response. Because the fact is, in most clinical trials of lupus, it's around the 35-40% mark. And in eprotuzumab phase 2, it was 20%. And that should have rung a very large, very loud bell, but I don't think it did. So, yeah, very disappointing. And I suspect Rich and other people are hoping the obinutuzumab data, which again looked reasonable at phase 2, isn't going to go the same way. That would be too crushing words.
So, in regard of the specific natural history and clinical management of SLE, there was a Dutch study showing that there was no increased risk of long COVID in patients with lupus. So, David, does this reflect your own clinical practice experience?
Yeah, so obviously when COVID came out, I and I'm sure everybody else was very worried that lupus patients who get it would be more at risk. In fact, we had a small number of deaths in our lupus cohort, but it was small, probably not more than 4 or 5. And I think the reason for that was very prosaic. I think our lupus patients hid away. They did not go out for months. They literally did not leave the house for months. And they refused to come up to face-to-face appointments for a long time. I did a lot of calls. And in fact, we had a horrific week. I remember about 2 months into the pandemic where we had 6 acute lupus admissions, 6. And none of them were for COVID affecting lupus patients, all with very severely active lupus. Those patients had stayed home until the very last minute. One came in with a cardiac output of 10%. She survived a month. How she survived, I have no idea. And we lost, I think, 3 of those 6 patients. And I'm sure they would not have died had they come in much earlier. But they just didn't want to come into the hospitals because they knew that's where the COVID was, and they just had nothing to do with it. So they stayed home. And ironically, that was probably for many of those patients the best thing to have done.
Richard, did you have, are you having an experience of long COVID in your lupus patients, or do you think it's exactly as the general population?
No, in fact, even short COVID, we didn't have a lot. So our health system is pretty large, and at peak, so that was March or April 2020, we had, on a given day, about 3,500 patients hospitalized across our health system. But as far as our rheumatic disease patients, we did not have a lot of patients who had COVID. And therefore, I'm not aware of any long COVIDs in our patients.
Same experience for us, exactly the same.
Perfect. It was also presented a French study, population-based, the Lupin F study that was presented by Laurent Arnaud, that suggested that the real-world use of high-dose steroids remains unacceptably high. And while on oral steroids sparing treatments, they were underused even in patients that had high-dose oral steroids. Richard, do you have any idea of data from USA that also emphasize this? What do you think could be changed for the population-based SLE use of steroids?
Yeah, I must say I don't have data. So are they overused? I really don't know. In fact, I don't even know numbers about who takes care of lupus patients. I think the people who see a lot of lupus are certainly aware of the hazards of steroids, and we keep lowering our threshold. But the people who are not in that category, they must think steroids are relatively benign, and they don't perhaps follow patients long term. I mean, I've been doing this almost 40 years now, and the amount of osteonecrosis and the osteoporosis, and I can go through the whole list, it really catches up with you over time. So perhaps rheumatologists, especially lupologists, have a greater appreciation of the hazards of steroids. And perhaps the physicians not in that category are scared of immunosuppressives and are afraid to use them early and add to that biologics.
I think that's very true. We into our unit, Raquel might remember because she's got a bit of time with us, we get about 25 new to us lupus patients a year, of whom about half, 50% are genuinely newly diagnosed patients, and about half come from elsewhere. And the patients coming from elsewhere, I'm often amazed at the high doses of steroids they've been given for weeks or months. It's quite amazing to me. I would like to think that word is getting around, and people should get the message, and need to get the message that the best dose of steroids, as far as I'm concerned, is the lowest possible dose for the shortest possible period of time. But clearly, it's not a universally accepted message at the moment, unfortunately.
And probably a good strategy would be with the patients' associations with lupus that would educate more the patients, and our turn also to educate more other colleagues that are not lupologists, probably.
Yeah, I mean, the other problem is patients like steroids.
Yes.
At least to a certain degree.
But they work fast. That's the great beauty of them. They very quick response. Great. In fact, it was you, Brit, who taught me that Benlysta response is very slow. I remember when it first came out, you've been using it, I had not used it. You said, you've got to tell them it could be months. And you were absolutely right.
And regarding also damage and mortality, in one of his presentations, Eric Morant showed how relevant is low disease activity as a clinical meaningful treatment target for SLE, since it predicts improved outcomes even without remission. So, David, again, what do you think about these results? Do you agree?
Eric is a great enthusiast and a great proponent of the LDAS, which he and his colleagues in Australia and Southeast Asia put together. And I think, look, in the simplest possible terms, clearly you want to get your patients into remission, which for me means no bilag A's or B's. But if you can't do that, then getting them to a low disease activity state has got to be a good thing. I think it's generally accepted that there is a link between activity and damage and death, and that was been shown by numerous studies over the years. So anything which gets the activity down is got to be a good thing. With the LLDAS itself, the Achilles heel of it for me is the fact that it uses the SLEDAI, which of course is a global score system, which excludes any disease in the gastrointestinal tract. It excludes hemolytic anemia, it excludes eye disease, and it doesn't distinguish the patients who are somewhat better from the ones who are the same, or the ones who are somewhat worse or not completely better. So that's a problem. And I've discussed this with Eric, actually, and his view is that, well, we use the physician's global as a means of covering that little gap over. My response should have been, I don't think I've actually said this in person, perhaps I should have done, is, well, if you think a physician's response or global is that good for those three elements, why wouldn't you want to extend it to the whole thing and sort of scrap using the SLEDAI altogether? But I haven't actually said that true. So I think I don't have a problem with it. Yeah, you reduce the disease activity as much as you can, and if you get it to remission, that's great. And if you get it to an LLDAS or whatever, that's fine too.
Richard, do you think that targeting LLDAS as a first step would distract from having remission as a target?
Oh, you're asking a guy who I just said a little bit ago doesn't like algorithms. No, I mean, I think we've all been doing this for years, whatever you want to call them. We've been trying to get patients with the lowest disease activity possible and sparing them toxic medicines as best possible. So I kind of do LLDAS or DORIS remission subconsciously. But I think the concept is important. And you compare, say LLDAS and DORIS remission to SRI, and I was very involved in the development of SRI. Mm-hmm. I mean, you could be an SRI responder and still have a lot of disease activity. So the fact that LLDAS or DORIS remission is targeting a state that's associated with less damage, I think is important. And we, haven't really shown that with SRI, or for that matter, the BICLA.
I think that you said something that is very important. You, as a very experienced lupologist, as David, you do have these targets well defined in your unconscious mind when you are seeing the patient. But this probably is a step to that for younger physicians and not so well experienced physicians that are actually taking care of patients. And do you think this is reasonable to think for not so experienced physicians to have as a target, probably?
I think they don't think in that way, and I guess it's up to us as the older kids on the block to try to teach them. But I totally agree with Rich that for years without giving it a name, I've certainly, and Rich I'm sure too, have been trying to get that activity down as fast as you can, so that you can start to reduce the medications as fast as you can. And in broad terms, I think younger physicians try to do that. They wouldn't necessarily think of it in terms of an LL-DAS or whatever.
There comes another work that was presented by Alain Cornet, representing Lupus Europe, that was actually performed during the European Lupus Congress on October in Stockholm. And questions were made to both physicians and patients to highlight what were their concerns during a flare. And they were not quite the same. Richard, do you think that are key communications that needs to be reassessed to physicians and patients so we can improve treatment outcomes? Because we need to have some kind of aligned communication so we have a better outcome. What do you think are the key communication for this?
Well, I'm not sure there's ever been concordance between what the patient thinks and what the physician thinks. We just concentrate on different things. We concentrate on kidneys and platelets and so forth, and the patients are concerned about cosmetic appearance and fatigue. Another problem is that we just don't have available therapies that can treat fatigue and reverse some of those constitutional symptoms. So I'm not familiar with what was presented, however. But yeah, patient communication is very important. And here in the US, and I'm sure it's like this all over, it's being compromised. We have 10 to 15 minutes with a revisit, and you have to get through the electronic record, which adds an incredible amount of time. Mm-hmm. And there's not a whole lot of time left over to talk with the patient. Though I must say, I don't use the electronic record when I'm with a patient. I will talk to them and avoid that computer.
David?
Yes, I agree with all of that. I find, I don't know if you're using the EPIC system, Rich, that's the one that we now have. But I remember being told by colleagues from the States, actually, when we were just about to introduce it, you will be seeing fewer patients. And my goodness, that was absolutely true. I see 20% fewer, and it's not because I don't want to see them, I just physically can't do it. It's the. By the way, I don't want to get started on Epic. It's too painful. So I entirely agree with you.
So one of the tools that both patients associations are talking about, and actually Laura presented, actually it was the PhD student of Laura that presented this study, is the LEAF study. So it's a computer web-based app that assesses fatigue and mood disorders in patients, and actually has a final part that counsels how to overcome some of the points they have. And they presented it, and more than 90% of the patients found it useful. David, what do you think about apps on lupus patients? Do you think they can help? Do you think they should be supervised? What do you think they can be?
So I'm reminded whenever I think of this sort of thing of a very famous old Marx Brothers film. I think it was called Duck Soup, which Rich might remember, in which Groucho Marx plays the part of the president of Fredonia, and he's presented with some war plans for the state to go to fight some other state. And he says, why? These plans are so simple, even a 4-year-old can understand them. And then he whispers to an aside to his assistant, run out and get me a 4-year-old. I can't make head or tail of them. And I feel like that. I feel apps essentially are for the younger patients. We have an adolescent rheumatology unit here, and it's almost exclusively done this way. They have apps for just about everything. And certainly for the teenagers that we have, it's absolutely great. For our 70-year-old patients, I'm afraid I have to tell you, it's not so great. And they have much, much harder problems just even coping with they walk into the clinic, they're supposed to sign in electronically, and they find lots of problems. So I think it's the future. I think it's the way it's going to go. And I think as our teenagers become 20, 30, 40, it'll be like, nothing to them. So I think, yes, I think it's what is happening. It will happen increasingly. And it's being used certainly in our adolescent unit to remind patients to take their drugs on a regular basis, to get them to come into the clinic at the time of their appointment and not 2 hours later when they feel like it. So in lots of ways, I think it's great, but I think for the older patient, it's a little bit more of a challenge.
Richard, do you have any experiencing with patients using apps? Do you encourage younger patients to use it?
That doesn't even come up actually in my discussions with my patients, maybe for lack of time, but I have no idea how they get their education. Sorry to say that, but that's the truth.
Yes, so that's one of the points that should be addressed by patients' associations also. Education should be also a responsibility, not only ours, but also from the patients' associations. Do you have any additional comments on the EULAR Congress?
Well, I was excited to hear, although this had come up obviously at the ACR meeting, and Rich and I revolved a discussion with George Shett, who really has put this on the map for lupus. The use of CAR T cells looks very interesting, very intriguing. Obviously, the numbers of patients are studied are small, follow-up times are short, but the notion that you could get a really, really active lupus patient off all drugs, and months later they're still off all drugs, is quite sensational, actually. We talked about telitacicept, and I think we mentioned obinutuzumab going from phase 2 to phase 3, and the potential use of voclosporin and anifrolumab, should I ever get to use it, would be very exciting. So for me, it sort of reinforced the notion that we are living in some very exciting times, and I kind of feel as if I'm in a crime novel and there's a denouement coming, and I want to stick around for the denouement. So I hope it won't be too long.
Richard, do you want to add anything?
Yeah, I'm going to add one drug that may be an up-and-comer, and that's ianalumab. And it took me about 20 minutes to figure out how to pronounce it. So that's an antibody to the BAFF receptor. So not only does it inhibit the BAFF pathway, but it also kills B cells very effectively. And we'll see what happens in future studies. But so far, looks somewhat promising, actually not just in lupus, but also in Sjogren's. So we've come a long way in lupus. I mean, our foray into novel therapy development was in the early 1990s with just 2 drugs, and those obviously failed. But we've learned a lot, and we have made some progress. So 3 drugs approved for 4 indications, and there will be more to come.
Perfect. David and Richard, thank you so much for joining me today and sharing your insights. To our listeners, we hope these discussions have helped you gain more of an understanding of the latest developments in lupus. Please download the Lupus Academy's EULAR 2023 highlights report from our website. A link can be found in the show notes. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world.